The emergency room was chaos when WNBA superstar Caitlin Clark collapsed during practice. As the medical team panicked, one nurse they'd been trying to fire for months stepped forward. What happened next shocked everyone in the room. My name is Maya Johnson, and I've been a registered nurse at Memorial Hospital in Indianapolis for 8 years. At 34, I thought I'd seen everything the emergency room could throw at me. But nothing prepared me for the night that would change my career forever and save one of the most famous athletes in America. It started like any other Tuesday evening shift. I was restocking supplies in Trauma Bay 3 when the ambulance sirens pierced through the usual hospital noise. Our charge nurse, Patricia Williams, barely looked up from her computer as she called out, "Johnson, you're on Trauma 2 tonight. Try not to mess anything up this time." The comment stung, but I was used to it. For months, Patricia had been building a case against me. Too slow, she said. Too methodical. Not aggressive enough for emergency medicine. What she really meant was that I didn't fit her idea of what a nurse should look like or act like. Being one of only 3 black nurses in a department of 22, I'd learned to keep my head down and do my job perfectly. But perfect wasn't enough for Patricia. The ambulance doors burst open, and my heart stopped. On the stretcher was Caitlin Clark, the Caitlin Clark. Even unconscious, she was unmistakable. The Indiana Fever's rookie sensation, the player who'd brought women's basketball into the mainstream spotlight. Her jersey was soaked with sweat, her face pale and drawn. 22-year-old female collapsed during basketball practice. The paramedic rattled off as they wheeled her in. Witnesses report she complained of dizziness, then went down hard. Vitals are stable, but she's been unconscious for 12 minutes. Dr. Marcus Richards, our head of emergency medicine, took charge immediately. At 45, he was brilliant, demanding, and had zero tolerance for what he called hesitation. He'd made it clear on multiple occasions that he thought I was too cautious for emergency work. "Get me a full CBC, basic metabolic panel, and cardiac enzymes," Dr. Richards barked to the team. "This is Caitlin Clark, people. The media will be here in minutes. We need answers fast." I began my assessment quietly, checking her pupils, monitoring her breathing, taking vitals. Something felt off. Her skin had a subtle grayish undertone that the overhead lights were masking. Her muscle tone seemed different. Not the relaxed unconsciousness of a faint, but something more concerning. "Maya," Patricia snapped, "stop hovering and get the IV started. Dr. Richards needs those labs now." I inserted the IV with practiced ease, but my mind was racing. In nursing school, then during my residency at Johns Hopkins before moving to Indianapolis, I'd specialized in electrolyte imbalances and metabolic disorders. Most nurses focused on trauma and cardiac events in the ER, but I'd always been drawn to the subtle underlying causes that others missed. Caitlin's presentation was textbook for severe hypokalemia, dangerously low potassium levels, but everyone was focused on more dramatic possibilities: head injury, cardiac event, drug reaction. I'd seen this before, particularly in athletes who overhydrated or had underlying conditions affecting mineral absorption. "Doctor," I said quietly, approaching Dr. Richards as he reviewed the initial lab orders, "I think we should add electrolytes to that panel, specifically potassium levels." He didn't even look up. "The metabolic panel covers electrolytes, nurse. Focus on your job." But the basic metabolic panel wouldn't give us the detailed breakdown I knew we needed. As I continued monitoring Caitlin, more signs appeared. slight muscle twitches in her hands, an almost imperceptible change in her breathing pattern. Her reflexes, when tested, were diminished. 20 minutes passed. The initial labs came back normal. Basic metabolic panel, cardiac enzymes, blood count. Dr. Richards frowned at the results. Run a CT scan. Could be a head injury we're missing. I watched them prepare to move Caitlin to radiology, and something in my gut screamed that we were missing something critical. In the chaos of a high-profile patient, everyone was looking for the dramatic answer. But medicine isn't always dramatic. Sometimes it's subtle, quiet, and easy to miss if you're not looking for it. Dr. Richards, I tried again, my voice steady despite my racing heart. Her presentation is consistent with severe hypokalemia. The muscle weakness, the altered consciousness, the way she... Johnson! Patricia's voice cut through the trauma bay like a whip. Step back. You're not the attending physician here. Dr. Richards finally looked at me, his expression cold. Nurse Johnson, I've heard about your theories. This is Caitlin Clark, not a textbook case study. We deal in facts here, not hunches. The comment hit like a slap. My theories had saved lives before, but they'd also earned me a reputation as someone who overstepped boundaries. In a profession where hierarchy was everything, being right wasn't always welcome if you were the wrong person saying it. They took Caitlin for her CT scan. I stayed behind, cleaning the trauma bay and trying to shake the feeling that we were missing something crucial. The CT would likely be normal. Then what? More tests, more confusion, while Caitlin's condition potentially worsened. 30 minutes later, they brought her back. The CT was indeed normal. Dr. Richards was visibly frustrated, and I could see the wheels turning in his head. A room full of the city's best medical minds, and they couldn't figure out why one of America's most famous athletes was unconscious. That's when Caitlin's condition deteriorated. Her heart rate dropped suddenly. The monitors started alarming. Her breathing became shallow and irregular. Patricia rushed to get Dr. Richards, who came running from another patient. What's happening? He demanded, checking the monitors. I looked at the readouts, and my blood ran cold. She's going into cardiac arrhythmia. Doctor, this is severe hypokalemia. Her potassium levels are dangerously low. That's why the basic panel didn't catch it. We need detailed electrolyte analysis and immediate potassium supplementation. That's not, Dr. Richards started. But then Caitlin's heart rhythm became visibly irregular on the monitor. In that moment, everything changed. This wasn't about hierarchy or who was right. This was about saving a life. Get me a detailed chemistry panel now, Dr. Richards ordered, and prepare potassium chloride for intravenous administration. The next few minutes felt like hours. The detailed lab results confirmed what I'd suspected. Caitlin's potassium levels were at 2.1 milliequivalents per liter, well below the normal range of 3.5 to 5.0. At those levels, cardiac arrest was a real possibility. As we carefully administered intravenous potassium and monitored her heart rhythm, I explained what I believed had happened. She's been training intensively for the playoffs. Excessive sweating, combined with possible diuretic use for performance or inadequate electrolyte replacement, led to severe depletion. The collapse during practice, the altered consciousness, the cardiac issues, it all fits. Dr. Richards listened, his expression unreadable. Within an hour of starting treatment, Caitlin's heart rhythm stabilized. Her color improved, and finally, blessedly, she began to wake up. Where am I?" she whispered. her eyes focusing slowly. "You're at Memorial Hospital," Dr. Richards said gently. "You collapsed during practice. You're going to be fine." As Caitlin recovered over the next few hours, the story of her condition spread through the hospital. The media outside was told she'd suffered from severe dehydration and electrolyte imbalance. True, but not the whole story. What they didn't report was how close she'd come to cardiac arrest, or how one nurse's persistence had identified the real problem when everyone else was looking elsewhere. Later that night, as I was finishing my shift notes, Dr. Richards approached my desk. His usual authoritative demeanor was subdued. "Maya," he said, using my first name for the first time I could remember, "I owe you an apology. And more than that, I owe you recognition. You saved her life tonight." I looked up from my computer. "I was just doing my job, doctor." "No," he shook his head. "You were doing what good nurses do, seeing what others miss, advocating for your patient even when it's uncomfortable. I've been wrong about your approach. Your caution, your attention to detail, that's not weakness. That's exactly what emergency medicine needs." The next morning, Patricia called me into her office. I expected another lecture about overstepping boundaries. Instead, she sat me down with an expression I'd never seen from her before: respect. "Maya, I've been reviewing your cases from the past year," she said, sliding a folder across her desk. "Your patient outcomes are among the best in the department. Your catch rate for subtle conditions that others miss is remarkable. I owe you an apology, and I owe this department better leadership." She paused, choosing her words carefully. "I've recommended you for our new clinical excellence program. It comes with a raise, additional training opportunities, and a role in training other nurses in diagnostic observation skills." 6 months later, Caitlin Clark returned to the court stronger than ever. She'd worked with nutritionists and sports medicine specialists to prevent future electrolyte imbalances. In interviews, she credited the amazing medical team at Memorial Hospital with saving her career, though she never knew the specific details of how close she'd come to tragedy. For me, that night changed everything. I learned that being different, being methodical, being thorough, being willing to speak up even when it's uncomfortable, isn't a weakness to overcome. It's a strength to embrace. Today, I lead Memorial Hospital's Diagnostic Excellence Program, training nurses to trust their instincts and speak up for their patients. We've caught dozens of subtle conditions that might have been missed, and our patient outcomes have improved dramatically. The emergency room still gets chaotic. Sirens still wail, monitors still alarm, and critical decisions still happen in split seconds. But now, when a nurse raises a concern or suggests an alternative diagnosis, we listen. Because sometimes the quiet voice in the corner has the answer everyone else is missing. And sometimes that quiet voice belongs to someone who doesn't look like what people expect a hero to look like, but who has exactly the skills and courage needed to save the day.